Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This podcast provides observations and commentary on JCO article bortezomib added to daunorubicin and cytarabine during induction therapy and to intermediate dose cytarabine for consolidation in patients with previously untreated acute myeloid leukemia aged 60 to 75 years by ELC Attar and others. My name is Jane Liesveld, and I am a professor of medicine in the Hematology Oncology Division at the University of Rochester in Rochester, New York, in the United States. My oncologic specialty is hematologic malignancies and stem cell transplantation. It is now 40 years since the combination of an anthracycline chemotherapy agent combined with cytarabine, the so-called 7+3 regimen, was developed for the treatment of acute myelogenous leukemia. While about 80% of younger patients will enter a complete remission with this approach, in patients over 60 years old, the complete remission rate is only about 50%. Means to improve upon these results are therefore needed in this older population, which will allow attainment of complete remission, generally required for long-term survival potential, without a substantial increase in toxicity. The goal of this study was to see if bortezomib plus the anthracycline daunorubicin and cytarabine would improve complete remission rate in older patients, and whether bortezomib added to intermediate doses of cytarabine during consolidation therapy could be accomplished safely. Why bortezomib? Bortezomib is a reversible inhibitor of the proteasome. It inhibits the transcription factor, nuclear factor kappa B, which is expressed in acute myelogenous leukemia blasts, as well as in leukemia stem cells, but not in normal CD34-positive hematopoietic progenitor cells. Bortezomib is approved for therapy of multiple myeloma, and in addition to its inhibition of nuclear factor kappa B, it has many other activities which may enhance its ability to suppress acute myelogenous leukemia cells. For example, it inhibits the unfolded protein response, stabilizes p53, induces apoptosis through the accumulation of BIM and BAX pro-apoptotic proteins, and alters cytokine and cell surface adhesion receptor expression. Furthermore, both nuclear factor kappa B and proteasome activity increase after chemotherapy exposure, and studies have shown that bortezomib interacts synergistically with anthracyclines to induce apoptosis in vitro. While bortezomib has little activity as a single agent in acute myelogenous leukemia, Dr. Attar had previously shown in a single institution study that bortezomib could be safely combined with idarubicin and cytarabine in both de novo and relapsed acute myelogenous leukemia. Of the 31 patients treated on that phase 1 study, 61% achieved a complete remission and 9% achieved remission without complete platelet count recovery. With that study as a prelude, in the present study, the Alliance group treated 95 older adults with previously untreated acute myelogenous leukemia with bortezomib 1.3 milligrams per meter squared intravenously on days 1, 4, 8, and 11, in combination with daunorubicin at 60 milligrams per meter squared on days 1 through 3, and cytarabine 100 milligrams per meter squared by continuous infusion on days 1 through 7. In addition, patients who entered a complete remission were able to receive up to 2 courses of consolidation chemotherapy with cytarabine, 2 grams per meter squared on days 1 through 5, with escalating doses of bortezomib, 0.7, 1, and 1.3 milligrams per meter squared, given on days 1, 4, 8, and 11. Dose-limiting toxicities were determined during the first cycle of consolidation. 41 of 62 patients who entered a complete remission were able to receive at least one consolidation course. The median age of the patients was 67 years, with a range of 60 to 75 years. 65% of patients entered a complete remission, and 4% had complete remission with incomplete count recovery. 11 patients developed grade 3 sensory neuropathy, and the highest dose of bortezomib tested, 1.3 milligram per meter squared, was tolerable during consolidation. The neuropathy usually improved with time, but long-term grade 1 sensory neuropathy persisted in some patients. No other significant toxicity patterns emerged during either induction or consolidation phases of the study. In the author's Phase 1 study, microarray analysis had shown that those who entered remission had a six-fold increase in CD74 than did those who did not achieve a complete remission. CD74 is a surface membrane protein which functions as a chaperone molecule for the class II histocompatibility locus antigen and as a high affinity binding protein for migration inhibitory factor. In this study, CD74 levels were actually lower in those who entered a complete remission, but no association with disease-free survival or overall survival was noted. The difference in CD74 expression correlation with complete remission rates between the two studies was possibly related to the fact that this study examined surface expression by flow cytometry, whereas the former study utilized gene expression profiling. While CD74 may not turn out to be the best predictive marker of bortezomib response, it will be important to identify signatures which might indicate a propensity for benefit from bortezomib addition in order to avoid the potential for prolonged grade 1 neuropathy in those unlikely to benefit. The authors conclude that further testing of this regimen is warranted. Given the complete remission rate of 65%, this does appear favorable, but randomized trials will be required to determine what contribution bortezomib has in contributing toward a complete remission. Also, the design of the study makes it difficult to distinguish importance of bortezomib in induction of remission as opposed to consolidation of remission, which is always difficult to achieve in older patients. Even in the study with addition of bortezomib, the median overall survival was only 12 months. Phase 3 studies will need to be designed to determine whether bortezomib in consolidation improves disease-free survival or overall survival, and whether the risk of neuropathy merits its inclusion in consolidation. It will be important to determine whether its use in induction and consolidation is indeed associated with minimal residual disease reduction and a change in leukemia stem cell frequency and functionality. During the time period of this study, 2008 to 2010, once per week bortezomib dosing, subcutaneous bortezomib dosing, and second-generation proteasome inhibitors have all been reported upon as means to preserve therapeutic efficacy with decreased risk of neuropathy and other side effects. Incorporation of these modalities into further trials would be ideal, and combinations of bortezomib with other agents in AML will also merit examination, for example, hypomethylating agents and histone deacetylase inhibitors. While the complete remission frequency in this study is an improvement upon what is generally seen with daunorubicin and cytarabine in this age group, should this be confirmed in a Phase 3 trial, will this be treatment changing? Or will it be just another wrinkle in a long list of 7+3 modifications, such as anthracycline dosing alterations, cytarabine dosing alterations, anti-CD33 antibodies, growth factor priming, and others? Will the addition of bortezomib during consolidation impact minimal residual disease and improve disease-free and overall survival? Well-designed future studies should be able to address these questions in a safe and timely fashion, as has been demonstrated by Dr. Attar and his colleagues from the Alliance for Clinical Trials in Oncology group in this study. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.